Okay. Hi, good afternoon. This is Dr. Ankur Lad from HORIBA. Yes, sir, ma'am, we are live. Good afternoon, everyone. This is Dr. Ankur Lad from HORIBA Medical, your host for today. I welcome you all to our live webinar. First of all, let me thank you for attending this interesting webinar. Topic is moving towards slideless practice, digital morphometry in hematology. Maybe this is the future of hematology. Laboratory automation has been for long limited to clinical chemistry and immunochemistry platforms. Throughout long history of laboratory hematology, the only reliable means for identifying, enumerating, and sizing blood cells has been represented by optical microscopy of peripheral blood smears. And we all are aware that the practice carries many drawbacks, since it is inevitably time-consuming, is vulnerable to high inter and intra-observer accuracy and impressions, needs specific education and training of microscopy, and is poorly suited for rapid diagnosis. And of course, we all know that storage is also a problem too. So, what is the solution? Whole world is moving towards automation and non-touch technique. So why not in hematology? Current scenario, in ongoing pandemic, leaves us with no choice, rather makes it imperative to move towards automation. So what is this digital morphometry? In digital morphometry, digital imaging makes use of digital images and software algorithm to classify hematological cells. Often one thing comes to my mind, that's why automation in hematology is due for so long. Is it because of EDTA sample or something else? Let's find out in detail. All about digital morphometry, its advantages and disadvantages, its strength and weakness. And for this, we have none other than Dr. Professor C.N. Srinivas. Dr. Professor C.N. Srinivas Chakravarti. He is Director of Department of Laboratory Medicine, Head of the Transplantation and Immunology and Molecular Diagnostic at the prestigious NIOT International, Chennai, India. He has done MD Path, Diploma from National Board, FCAP, PG DHRM, EMBA, and MLE from the prestigious Harvard University. And for making the session more interesting, interactive, and lively, we have guest panelists, Dr. Anupa Dikshit and Dr. Gautam Gopal Bhagwat. Sir, we are honored to have you as our speaker. And so to begin the session, I would like to invite Dr. Srinivas sir to enlighten us with his expertise and knowledge on digital morphometry. Over to you, sir.
Yes, please.
Yeah, sure, sir.
So, good evening, ladies and gentlemen. At the outset, I would like to thank all of you, as well as the host, HORIBA, and also our panelists, Dr. Anupama and Dr. Gautam, to join in for this interesting session. I feel so, because we are talking something about a sideless practice for the hematology. And as well as Dr. Ankur was saying that the automation in hematology was there for 3-part analysis and the 5-part analysis. But when we started doing more automation and exploring more automations in that of the hematology, we started understanding that hematology can be automated fully also. So we will be spending about 30 to 35 minutes on how the digital morphometry is helpful in hematology itself. So I would like to thank HORIBA because they have well placed this webinar during the National Pathology Week, which is celebrated between November 1st to November 7th, all the time, all through all the years actually. So this year, the theme of the National Pathology Week is Pathology at the Heart of the Healthcare. Really, it is true that when we are undergoing this very bad pandemic globally, the laboratories which are backed up by the laboratory professionals which are disclosing the pathology of the human being is the heart of the healthcare. A small note from NIOT is that wishing you all a safe practice of laboratory medicine and a good deliverables for our patients to have a healthy and a bountiful healthness, mindfulness for all our society people. With this, let me introduce you what will be the objectives of this talk. Very simple. We'll just have an introduction to the steps in the manual review of the peripheral blood smear, a bit of principle along with the history of the digital morphology, how best we can utilize the digital morphometry to our convenience. Of course, we have the drawbacks also, and some case studies how we have utilized this in the time of this pandemic also. The importance of the blood smear is very, very understood for every laboratory professional. And we should understand that the peripheral blood smear is important for diagnosing, ruling out, or for prognosticating any of the hematopoietic disorder or the metabolic disorders or the systemic disorders itself. But most of the time, the blood smear study are kicked off by any of the three things. Either you have got a flag review criteria as per the hematology laboratory rules, what has been set up independently in your laboratory. Next, you require to confirm the findings of an automated hematology analyzer, or there may be an added request from the clinician that kindly do a peripheral blood smear study for this patient. So these are the three scenarios which we might encounter the blood smear study as per the test request forms, or by confirmation of the automated hematology analyzer, or a flag review criteria as per your laboratory. Now, when you're doing the peripheral smear examination, we all know that it will try to bring out the morphological abnormalities or the type of the anemia, qualitative and the quantitative disorders of the WBCs, as well as quantitative and morphological disorders of the platelets also. In addition, it will also give a clue or a sign to what type of disorder this persons may be undergoing. For example, if you see a megaloblastic anemia, the person may also have a polyglandular autoimmune syndrome. So you're giving a hint to the clinician that, look here, this person is already having megaloblastic anemia, but also explore whether this guy is having a polyglandular autoimmune syndrome. As I told you in the beginning, the peripheral blood smear study has got a process. So what is the process? We'll start from the EDTA blood, which has been given to the automated hematology analyzer. So you have got a CBC from the automated hematology analyzer. Next, we do a blood film preparation is done. Staining of the blood film is done. Then it is brought onto the microscope where the morphologist or the morphometrist or the pathologist is going to have a look at it. Then we are going to have a thorough slide examination, give our data collection, and make a report of the same. Now, when you're looking at this 6-stage process from the blood film preparation to data collection, all this are having lot of steps which are known to give errors. Okay, so if you really study this as a process mapping and do the error proofing study, you will come to know that there are a lot of errors which could happen at this each stage. To summarize this in a small capsule, I have got this. So we have disadvantages like this. The resolution of the microscope may be wrong. Inconsistencies among the personnel or the staff deficiency may be there. You might be having a mixed malignancy because of the leukopenia, or you might have an incompetent person sitting in the microscope, or they are not able to pick up or screen initially the smears and give it to the pathologist. A remote consultation is not possible if you want to take immediately an opinion itself. Storage of the stain slide becomes very, very impossible. And the data archives or the delta check cannot be possible at all with the manual preparation of this. In addition to this, if you look the staining process itself, the staining process involves control and stock inventory of the chemicals, good quality chemicals. pH should be always monitored. Coming to the microscope, most of the time the microscopes what the screening people uses are that of a person who uses a hi-fi microscope like a Leica or an Icon may be entirely different, having a field of view when compared to the local made microscopes itself. The microscopes also matter because the light intensity also is an important factor. We are talking about the light source of the tungsten lamp or a halogen lamp or an LED itself, which might be important for the good resolution itself. Now let us go in detail about how we can work smarter in the scenario of the digital or digitalization of our laboratories itself. Now, what are the drives which are getting for the digital microscopy itself? So there are 6 points which we can take it. Let us take the first one, which is very important now, is that cost efficiency is very important. So what do you mean by cost efficiency? When you are able to give a value addition for a simple test by having unlimited number of services, then you will have a good cost efficiency. That is, you are saving the time, you are increasing the productivity, your accuracy increases, and the precision also increases. So what happens? It requires actually a demand of efficiency itself. So what do you mean by that? Shortage of the labor can be avoided. That is again a market drivers. Next, consolidation is happening in other field of laboratories itself, more particularly with the chains of laboratories when they're undergoing the big problem is that how will I review the smear which is having a leukemia? How will I have a review a case with thrombocytopenia? How will I review with the case of about malarial parasite itself? Then patient safety and patient value becomes important. And of course, the higher quality is also needed for better quality of reporting itself. Now, when we talk about the digital era, simple thing, it started in the year 1966 from Sweden with this company having a scanning microscope. In 1974, we had one more company called LARC, which had image processor and later on cropping, and then we have analyzed it. From 2000 onwards, a company called Cellavision, based in Sweden, is taking care of this brand of what you call as a digital morphometry in place itself. Now, what is the current workflow and what are the challenges? Let us see before going into the implementation of the digitalization of the slides itself. Whenever we get a EDTA blood sample, I have told you that we are doing a process mapping now. So you have a hematology analyzer. If the results are within the range, no flag of criteria, then automatically it will go for the LIS and the reports are released. Now, suppose you have a flag of criteria or you have rules set up in your hematology laboratory for the abnormal results or abnormal flagging. A peripheral blood smear is made. It means stained, screened by the technological staff or the laboratory professionals. And if it requires to be seen by a pathologist will be seeing it. And if he requires to go in for a second opinion, then it is getting transferred to the senior consultant itself. During this process, these are the questions which I have posed, about 5 questions which I have posed for ourselves to understand, are we doing the right thing? First question is that, how am I assessing the competency of my lab staff? Are they doing good or bad? What are the tools we have for the staff training who comes new or old or retraining itself? Next, we are going to talk about whether we are going to have the abnormal cells missed or correctly identified. Are we doing the proper grading of the RBC itself? In addition to this, we have another problem is the physical transportation of the slides to another one location. And which cell is abnormal? For you, at one particular point, you might be having the abnormality and you want to mark it. And you have to send the slides to someone. So during the transportation, there may be slide breakage, or there may be dissolution or total disappearance of the marking itself. So these are the problems and the challenges one will encounter. Next is that the pathologist saw, and he wants to share with one more pathologist to make sure that doubly sure that it is right or wrong. And that pathologist may be within that city or a town or a hospital, and it might require immediate opinion. So in these scenarios, if you put yourself, you do feel sometimes that the mobile phones can act as a small morphometric measure where you click your photographs from that of the eyepieces and you can transmit it. But how are you going to preserve them? How are you going to store them? So it is a big question for ourselves. So the severe review reputations can be summarized like this. It is labor intensive. What do you mean by that? Per slide, the WHO says very clearly that one has to spend at least 6 minutes to give time for each of the peripheral smear. Suppose a smear has come for malarial parasite, the advocated guidelines say that a person can utilize this. Okay, the person can utilize the slide timings as 20 to 30 minutes. Then only you can say the smear is negative for malarial parasite. Suppose you have got a blast cell to search for. The time allocated for searching is about 35 minutes. These are as per the guidelines what I am saying. So that you mean by the labor. Next, it is not standardized. What you mean by that? It is subjected to subjectivity. And platelet, which is looking like a giant platelet for you, may look like a micro mega karyocyte for someone else. So we should be very clear that whether what we are looking is a micro mega karyocytes or it is a giant platelets itself. There are a lot of differences with that. Next is you cannot have a delta image check. Now, what do you mean by a delta image check? Suppose you have identified the first time, the first visit, you have got a patient with leukemia. You have identified that XYZ is having a leukemia and the blast cell count is about 40%. After the chemotherapy, the same blood sample is coming to your laboratory again for the peripheral smear. We should have a historical check to understand that what is the blast cell count now and what was the blast count before. So that becomes the delta check. And you always have a limited consultation with your own peer group. And if you require any help, you will not be able to get it from the second pathologist who is not there in your place. So the technologies have come together from the company called Cellavision. I'm not here to promote any of the company, but what product we are using, we are just sharing with you people. You have got hardware and software, and more details you can have from this company website itself. Now, this I put in a nutshell for easy understanding and what are the challenges which we spoke about. Now, you remember this diagram because we have to come back to the diagram because we have to understand whether the 6 pillars which are called as the challenges in the hematology diagnostics are being fulfilled by the digital morphometry. We have to understand. So what are the 6? Let me list out for you. Pressure to do more with less. Just with 50 microliters, you want to know what is the disease this person is having. Skill shortage, that is what I mean by a personnel who's been trained well in hematology, especially to identify the blood cells, are lacking in a lot of places. Shorter turnaround time. I told you that if you want to screen one peripheral smear, you require 6 minutes. But if you want to make it before 3 minutes, then you have to think about innovation. Greater levels of standardization and consistency so that you bring in what is called as objectivity for your hematology morphometry. Next, connecting to your leaders. What are the leaders? Who are the leaders? So if you have a regional leader, if you have a regional group of society who can authorize and say that, yes, doctor, what you are seeing is right, it becomes very easy. Then you have traceability and quality control for your smears, staining, as well as for your morphometry itself. So these are the 6 challenges which we are going to see later how it can be solved by the digital morphometry itself. Now, in addition, the management questions, why you require this digital morphometry. When you're looking in for the management convenience and what we call as we have to convince them, we have to talk about 4 things. So these are the 4 things on which we can convince the management. How you're going to promote the quality, which I'm going to talk to you. How you're going to promote the proficiency among the technological staffs and the pathologists. How we are going to improve the connectivity by bridging across your clinicians where they want to see the smears, or your own peer group who want to see beyond your compound, or the global leaders who can help you out. And you can also bring in the improved efficiency for the peripheral smear reporting itself. Now, this is how the technological shift will be. A slide is processed now. You remember the slide process, what we told about the manual processing. A slide is processed now with the stainer. It goes, gets stained, comes to that of a digital morphometric point. Then the slides have been pre-classified and characterized. Then you can do a verification, and then you can do a secondary remote review verification, and you can sign it. We'll go in details with this. Now, what happens in a digital morphometry, with particular to the digital morphometry, what we are talking? Understand that there is a small difference between the whole slide imaging as well as the digital morphometry, though you might be having the optics as a similar look. So this is like saying that you welcome abroad and the air hostess say you will be a frequent flyer programmer, but this flight may be having separate safety precautions. So you get on with that simile, and the same thing I'm talking to you here. Your cell imaging with that of the whole slide imaging with the histopathology and the morphometry may be having the similar options or similar practices or the similar principles, but there is a small difference here. So what is the small differences we are talking about? I've just highlighted here. You have inside the CellaVision a relay tube or a digital camera. The relay tubes are particularly having the 10x object. Sorry, the relay tube are having two types, 0.5x and 1x itself. So you have got 100x objectives. Here you can see here down below, and you have got a 10x objective also, and you have got a LED table which emits the light. The slide sits over here. It gets scanned in 10 objective, as well as oil is dispensed before it goes into the 100 objective, and the images are captured through this. Now, if you take a 10x objective, a monolayer search is usually done for the WBC, and the location of any nucleated cell is identified, and they're going to check for the stain quality. I'm going to show you how they're going to check for the stain quality itself. Later on, you have got a 100x objective to get into work, where it is going to go for a monolayer search itself. That means to say that the slide moves until you get a monolayer of an RBC, where the oil is dispensed, and then 100x sits over there. So by that, it is going to take 21 different morphologies, count nearly around 3000 RBCs to give you the pictures. Okay. Now that you have to understand. Next, how is the WBCs being done? Okay. Now the WBCs, where the monolayer, you have got a WBC. So if you take these are the digitally slide stains over here. So there is an imaging which goes like this. So it does what is called as scanning, and it comes to the area where you have got a thin monolayer here at the edge of the junction of the body and the tail, makes a fixed point and makes sure that it takes up 10x and 100x also. With the 100x and the 10x, it is going to get you the WBCs and the RBCs itself. So it does continuously the scanning, and it is going to bring in the classification also according to the ANN. I'll tell you about the ANN in a few minutes itself. So basically what it works on a simple microscopic principle itself. You have a light source, you have the eyepieces, you have got the relay tubes which will capture the images and will push it to a computer itself. I'm not going in detail about the resolutions, the pixels, and all, because my principal aim is to tell how digital morphology is useful. If you require more about it, you can get onto the ICLH, or you can go into the ICSH platforms and you can look into the digital morphometric papers itself. Okay. So now what happens here? Let us see. What is ANN? I was talking to you about what is ANN. ANN refers to the artificial neural network itself. Now, the artificial neural network is based upon 6 characters. Okay, what are the 6 characters? The form of the cell. Okay, what is the form of the cell? What's the color of the cell? What is the texture of the cells? And do we have any vacuoles inside the cytoplasm? Or probably will I be able to pick up any functions other than this, and the wavelets, which are small, tiny wavelengths, which are getting picked up by the relay lens itself. So here, if you look in the peripheral smear, what has been focused here, you have got a lymphocyte and you have got a neutrophils and an RBC and the platelets itself. So beautifully, it is able to say what is the cell membrane, what is the nuclear dimensions, and do we have the nuclear loops over here, and all features are put into one capsule and it is pushed into the neural network of a software package which is available in the CellaVision, and it is going to characterize into these many cells. So that means the WBCs, when you're seeing on a computer output from a CellaVision, you will be able to know these classes are available. So if you see, you have got band neutrophils till that of the monocytes, lymphocytes, promyelocytes, metamyelocytes, blasts, then you've got a plasma cells, and you've got non-WBC classes also, like the nucleated RBC, giant thrombocyte, thrombocyte aggregations, smart cells, and the artifacts also. So this comes as a capsule from the WBC pre-classification. Now, how does the print screen look or the screen looks? It looks like this. I just clicked it from there. And you have got these are the neutrophils. And you have got here on your left-hand side, the list of the classified products, what you have been there. And you can go individually and click this also to make sure that these are the neutrophils. Or if you want to reclassify, click on the right button of the mouse and you can reclassify it. That's called review and reclassification itself. Now you want to have only one screen you can have, or you want double gates, you can have double gates here, or WBC or 2 galleries you can have with the reference cells also. So there is a reference image atlas also given in the software where you can say whether you are correctly identified the picture here. So the blue things what you get here, the blueprints what you get in the small tiny dots is that it's compared with that of the reference images itself. Now let us come to the RBC. Now, when you're talking about the digital morphometry, the CellaVision actually counts 3,000 RBCs, and they classify into these groups of cells based on the morphology, based on the cell type, and based on the inclusions. I'm not going to go in individual thing, but I'm going to tell about the morphology, the cell type, and the inclusions. Now, how do they look on the print screen itself? So this is a very beautiful function of the CellaVision itself, where you will be able to see the classification or the differentials itself. And in this left-hand side, you already have got the color, the size, and the shape. And the red window says that these cells are identified in this slice. Now, suppose you click on the classification. You want the classification, you get a WBC, you get an RBC differential, where itself says that how many target cells are seen, how many cystocytes are seen, how many helmet cells are seen, and how many the sickle cells are seen. Now, when this will be helpful to us, there is a guideline, if you would have known about that, or if you don't know, you can go through it. It's called as a peripheral review grading of the RBCs. It says that what should be the percentage of the cells to classify into hereditary ovelocytosis, how much of percentage of cells you want to have for fragmented RBCs to diagnose a case itself. So for those cases, this will become useful for us, and it is easy for every person to get a standardized look of what the cell morphology looks into. A beautiful feature which has been adopted, which we cannot do from our eye, which has been captured by the CellaVision. Come to the platelet. When we're looking for the platelet, there are two advantages. When you click on the platelet onto the button over there, it opens up this window. Now, if you see, you have grids here. So you have got 9 grids here. You have platelets in all this, and you can count. And you have also have hollows on the left side. You can see the blanks over here. You have got a 3 into 3 squares, and you can just go on putting say 3, 4, 5. You can do a manual platelet counting. Especially important from thrombocytopenia, you want to confirm the hematology value to that of the digital morphometry. You can go ahead and do the platelet count on the machines also. Now, in addition to the peripheral smear, the CellaVision is also capable of doing 2 more important things for us. It can also help us in pre-classifying the body fluids, which are already cytospinned. It's a cytocentrifuge preparations, where it is going to give you the pictures and the classification of the cells, which are seen on the left-hand side. And it will also have the region of the interest, which you can tag it for someone to review. I was talking to you that if you want to mark an area, you want to show it to the consultants inside or outside your laboratory, you require to mark areas. So with the digital morphometries, you can do it whether it's a peripheral smear or it is something to do with the body fluids. You can mark those areas and you can send it. You can classify up to 5 cell types itself, and the abnormal cells are usually sent as other. Okay, suppose it's a malignant one, it says as other cells. So the CellaVision has got a beautiful software. In addition to the remote review software, you also have a server software. A digital scanning tools are provided, and the dashboard is also there. In addition, you have got even proficiency tool as well as an app for your smartphones called as the CV Atlas, which is very useful for all of us. So let us see whether we overcome the challenges by implementing the digital morphometry. First and the foremost is that, do we have a remote? Yes, CellaVision can provide remote review, and you can email and export it because it can be transferred into JPEG, or you can send into TIFF also. Whether we can mark the abnormal cells, yes, the region of the interest can be annotated. You can mark the image and you can share it with your colleagues also. Do we have the capability to miss an abnormal cells? No, because it has got 100% sensitivity in the blast cells. And we have to understand that before you put these machines into use, you have to take at least 50 abnormal slides. Do the verification with the manual microscopy with 2 observers, and then on to that of the digital imaging itself. So once you assure yourself that these machines are good enough to equal to that of the human, then you can go ahead. Of course, there are certain advantages of the digital morphometry itself. But what I want to say is that if you want to verify for the abnormal cells, this is how you have to go ahead and do the verification. Can we do the standardization according to the ISL guidelines? Yes, you can, because the machine gives you the grading itself. You can review and resort it. Secondary opinion can be done. Yes, it can be done by this. Then staff training becomes very advantageous because you can tell them to just simply see this case, do the classification, and give the review itself. So it becomes easy for the competency development itself. So I told you that the 6 challenges, let us see whether it has met it. Pressure to do more with less. Yes, it can give you a simple cost-cutting, faster processing of the slide. Now, I told you that manually we require to spend about 6 minutes per slide. Whereas CellaVision, we can finish it within 3 minutes. Okay, within 3 minutes, you can classify the WBCs, the RBCs, including the parasites. You can pick up and you can say that, yes, this is abnormal. Can I overcome the shortage of the skill staff? Definitely. The skill staffs can be posted in different areas so that the machine automatically from the stainer can be transferred to that of the module of the CellaVision, where it goes for the scanning and it sits in there, and leisurely one can look at these smears and then they can pass it on to the pathologist itself. Shorter turnaround time, of course, I vouch for it because it takes just hardly about 3 minutes to finish one slide for the review itself. And you don't miss the abnormals. Traceability of the quality at the superior levels, it's important, which I told you. I'll show you how the traceability of the quality can be brought in over here, and standardization and delta checks can be done. CellaVision also has got a flexible use between the labs. If you're having a central lab to that of a peripheral labs or a satellite labs, there is no need for transport of the slides itself. You can annotate the slides, ask them to come on to the remote consultation, and you can go ahead and do it itself. The last one is greater levels of standardization, reduction in the inter-observer variability, and promotes consistency. In addition to all this, in my practice of about 2 years, I have seen that every day is a learning in CellaVision, because we recently published about 3 or 4 cell images on the ASH, and it was really benefiting to gain the confidence when it is accepted at the global level. So the management needs it also benefited, where you have got promotion of the quality for the accreditation purpose or for your own patient safety. Efficiency can also be brought about because you are having a reference bank you can create, you can add on, and updates are going to happen every often. And you have got a reference library for connectivity with that of the global people also. And it also automatically locates the slides, cells, and also pre-classifies the cells itself. So let me just go to the practicality in adoption. And I told you that this machine can get in to understand how you can utilize it to the best. So the first thing is that let us see quality. I was talking about it brings in some quality and standardization. So I have put a slide here with the smear on the right-hand side, and left-hand side is from the CellaVision for the quality check itself. You can see 2 meters over here. I really remember our car speedometers or audiometers there. So you have got a meters with a barcode over there, which talks about the stain intensity and the stain color. And this is a good one because it is showing in the green zone itself. Now let us talk about what is the slide here with the barcode. You have got here the red zones and the green and the yellow zones. If I see on a slide which has been scanned the green zones, that means this quality of the stain, the quality of the smear is very good. Okay, that means this slide which has gone into the Cella Vision to check for the quality is good for the smear preparation. Good stain quality, because I'm seeing the smear color is good on the meter, and the another one meter I'm seeing the stain intensity also. Let us see if I put a bad smear, what does it show? See here, this is a bad smear preparation itself. There is no meter over here, and there is no mark. You have got no mark here, and if you see, there is only red. There is no green here at all. So that means this is a poor quality stain making. One of the prerequisites for digital morphometry is that automated smear maker and staining. If we don't have an automated smear maker and staining, your digital morphometry will not be of use. Please understand this. So when you are going to convince the management, you have to convince the management in such a way that you will get green signal for the automatic smear preparation, stainer, as well as the digital morphometry itself. Otherwise, it will be difficult for you to get a good quality output from the digital morphometric machines. Now, poor stain quality. Suppose you have got stain marks in the slide. See here, it has got very bad. You have got a very dark smear color, and the stain is very poor. And if you look at this, even the smear is very bad here. They don't have much of green color in the slide preparation at all. So when you have this, you have a standardization bringing in for your quality. This can be plotted on an LJ chart where the machine itself will give you, and you can mark your LJ chart for the quality checks of the stain smear making both together. Now, how does the RBC menu look on the screen? So on the screen, the RBC menus looks like this initially. This is the left side. You have got all the preset classification according to the ICH grading. You have got boxes over here, and you have got T+, 4+, all those have been reported. Suppose you want to go for a differential of the RBC. We are talking about the RBC differentials. Okay, this is a characterization, what it can do it. Then if you go for the differential. So if you look for the differentials, this is when it gives you. So you have a differential options here where it can be grouped into that segment. So this is an elliptocytosis, ovalocytosis, or you have got some teardrop cells. It pre-classifies and gives you to understand what is the percentage of the cells you are seeing in this smear itself. Very important when you're going to look out for hereditary ovalocytosis, hereditary epileptocytosis, more important for fragmented RBCs. During the COVID epidemic, okay, or the pandemic, what we can call, when we were having the peripheral smears from this COVID patients, we used to put for the FRBC functionality on your automated smear maker, as well as that of the automated differential count to know whether what is the percentage of the FRBC on the automated hematology analyzer, and also go for RBC differential from the Cella Vision to understand, do we see any cystiocytes here? More than 3% becomes critically important, and we have to inform the clinician that I am seeing 3% of fragmented RBCs, correlate with that of the LDH to understand whether this patient is having hemolysis. Now, image matchmaking. Now, suppose the technical staff has got a difficulty, or as a pathologist, we want to verify whether I have classified cell is right or not. You can go for an image match, and this blue color, when it comes, it says that it matches with that. So you can see a matchmaking program here. It's not a matrimonial alliance as you are seeing now, but you can say very clearly that it matches 100% to the image library, and you, with confidence, you can release your report saying that there is a match. The same thing happens even for the WBC also. Now let us see some utility of the machines in the digital morphometric era and how it was useful. So let us take this first case, 21 years old male, sorry for the spell, history of the road traffic accident. The routine CBC was sent. So this was the CBC you have got some macrocytes, and you have got some all this. So what I told you in the beginning, whenever you have got any flag of criteria, you have to review and you require a peripheral smear. So the same thing was done as a peripheral smear, and it was reviewed. See, the Cellavision gives this picture. Immediately within 3 minutes, you can say that you have got Rolu formation in this. Does not have dimorphic population as we see in our peripheral smear, but peripheral smear of the same was confirmed that he had the Rolu formation. Total protein was very high, and the serum protein electrophoresis were ordered for this case to understand that he had a myeloma here. So surprisingly, you know, this age, 21 years, a dimorphic picture really confused us. But immediately within a span of about 3 minutes, we were able to tell to the clinician that this is a pathological fracture. Probably it was a coincidental that he has a road traffic accident. Kindly evaluate for the myeloma itself. Next, let us see in SARS what happened. 37-year-old female, she was SARS-CoV-2 RT-PCR positive. We know that during the positivities of the COVID patients, they usually have neutrophilia. So here you have a neutrophilia in this patient, and you have got 12,000, and you have got a neutrophilia also in this. About 11% of this is going to be 11,000 of this is a one which we have got. But let us see what is the peripheral smear. Peripheral smear is totally different. You have got agglutination. Now, in the hematology analyzer, if it would have been agglutination, your indices should be abnormal. In this case, we never had any flag off at all. Since we had set the criteria that any patient who is coming in with history of RT-PCR positive, every blood smear will go for a staining and review. We were able to pick up this cold agglutination. Otherwise, this would have just gone like that. That's why I told you, individually the laboratories has to have their own review criteria to make sure that they'll be able to give you a value addition to the patients itself. So it's very, very important. So this was a case of a cold agglutination in a COVID patient itself. Now let us see one more case during the COVID patient. So it was a 45-year-old male. Again, I told you there was no flag of criteria on your hematology analyzer, but the smear was sent to the smear making and Cellavision. Here you can see our technical staff are annotated some cells over here. Okay, there's no flag off here in this RBCs, but you have seen that our technical staff has made an annotated image. This image came to us on the night duty itself, and they were able to share this with us. And further imaging of the same cases, they had put it over here. And you see parasites have been flagged off in your Cellavision. The Cellavision is able to do sometimes the flag off of the parasites in the RBC, or during the platelets functioning, you can get this parasitized RBCs also can be seen. The advanced machines are also able to give you the percentage of the parasitized cells. You can get even the index, parasitic index also, you can get it in the advanced versions of the digital morphometry itself. So let us see the higher magnified power in that of the platelet ones. So again, you get the ring forms here. So we are able to pick up the parasites at the gist of about not more than 3 minutes to 4 minutes. You can pick up the malarial parasites and confirm the species, and you can tell your clinicians as a critical alert itself. This is a recent one. If you see, it's on 1st of November. A 17-year-old lady, she had a blindness of a recent onset. CBC was sent over here, and you can see that on hematology machines, we know that scatograms are abnormal. And you want to say immediately to guess what is the report, you can just put on the Cellavision, you have a pre-classified group of blast cells. And you can see that there is a blast cells over here, and you can immediately see the blast cells having flagged off by your machines, along with the percentage saying that it is more than 40%. So wonderful is the digital morphometry that within a span of about 3 minutes, you are able to get the blast cell count, you get the confirmation. If you want to have a reference image, you can do a reference image and you can get it. Fifth case is again an RT-PCR positive case, but you can see that you have a beautiful platelet aggregation here, and you have to go in for a secondary request to give a new smear or a new CBC should be coming up because it's got a platelet aggregate. Now, in the same case, what we saw was this beautiful vacuolations in the neutrophils, which are classical of the COVID cases itself. These vacuolations are basically because of some bacterial infection or the sepsis itself. And in the same patient, we were able to see the micro megakaryocytes. See, this is a micro-megakaryocytes. A micro-megakaryocyte has got a granulated nucleus, has got a vacuolated cytoplasm rim around it. Whereas if you see in this, this is the arrow, what I'm showing is a giant platelet. It has got only the nuclear, that is a cytoplasmic fragment only. Does not have a nuclear gamete over there. But these, again, a rim. Again, you see that you have got a micro-megakaryocytes over here. Now, in addition to all these routines, sometimes you will be surprised because as a pathologist and a morphometrist, you love to capture some unusual cases which you can see. Since about 26 years to 27 years, I'm in practice in the laboratory medicine doing this hematology work, but we were not able to get such beautiful pictures and abnormal cells in a gist of time. So I'll show you one of the unicorns over here. So this is one case. This is a beautiful rosette of the RBCs around the neutrophils. This was a case of 47-year-old male, chronic kidney patient on dialysis, had hypergammaglobulinemia, polyclonal gammopathy, and RT-PCR was negative. So we were so thrilled to see the cells, captured the picture, and we submitted to ASH. So when we submitted to ASH, it got published within a span of 24 hours. And this is available on the ASH image network, which gives us confidence for the whole group of the hematology team led by Dr. Satish Ramanathan, Madhivanan, who is my technical staff, the lab manager Vijay Kumar. And I myself, we were so happy to see that it got published within the span of 48 hours. So it really gives boost to the people to say that your slides are of global quality and it can be accepted immediately by even the international group. Another one is very rare, but I want to tell this because it was found out by my lab in charge, Madhivanan, who brought this case. Hematology analyzer showed this snake. This is a blue snake, which you can see from the hematology analyzer. This is abnormal. Okay. Now, in the tube, he was able to see some fat debris like this. Okay. Now, what he did, he took this fat debris and put it under the microscope, and he saw fat globules like this. Let us see the CellaVision images. The CellaVision images shows huge flat globules which have been engulfed by these neutrophils. This is amazing. Such beautiful cells which are very rare but of clinical importance. This CellaVision is able to bring it out and produce it to your eyes to say that even a beginner can say that these cells are abnormal, and you can suddenly get this at any point of time in your career. So this also got published in the ASH, and we published this as a fat embolism in a COVID case here. You can see this has been uploaded in the ASH image banking. I'll tell you, this is amazing because the image banks are a place where you can feed your images, get an approval from the global peer group, and you can publish this within a span of 48 hours. Another one was this Unicorn 3, which I labeled as a Hubble-Jolly-like inclusion bodies. What is this Hubble-Jolly-like inclusion bodies? When you see the neutrophils, you see distinct purplish dots, which are bigger than the Hubble-Jolly bodies, but it reminds me of an RBC of this, but they have labeled this as Hubble-Jolly-like inclusion bodies. And this becomes critical when you have got drug toxicity with respect to tacrolimus or ganciclovir. Whenever you have got a ganciclovir therapy or when the patient is on tacrolimus, if you see this Hubble-Jolly-like inclusion, it is critical to inform to that patient. It can also happen in myelodysplastic syndrome, or it can happen even in a patient when the patient is having sepsis. And we saw in 2 cases with COVID with sepsis also. So such beautiful images can be obtained, which are of critical thinking, good for the patient, adding values, and good efficiency you can get it. The last one is that you remember the first slide I told about 21-year-old guy who had a Rollup formation. The bone marrow of the same patient were uploaded on with the CellaVision, and you can see the bone marrow also can be done. I told you about the body fluids. Here I'm talking about the bone marrow also. That is one of the utility of the CellaVision, where you have got the bone marrow of the same patient you are seeing with the monoclonal gammopathy, and you see these are the classified plasma cells you can see. So in just you can say that the digitalization of the morphometry makes us very clear that we don't want to check the glass slides at all. Today, after being with the CellaVision for about 2 years, I feel that my work is very comfortable with the CellaVision, and I love to go to the CellaVision except for a few slides which I require to do a scanning for that of review of of the class slides itself. Now, this is the last one for you people. This was of recent origin. So we got this in one of the dengue cases where you had got some granules in the plasma cells. And this is snapper-needed granules in the plasma cells, which happens in either a reactive case or in a lot of a malignant conditions of the plasma cell dyscrasiasis also. Now, in addition to all this, I started this digital art also. So what I did is simple. Take some pictures and make some emojis and try to put it on the social network to make our mundane work very happy. And you won't believe that this becomes a hobby right now, and you can start doing this even with the CellaVision itself. So make sure that you have a happy and a safe Diwali. Take care, stay safe, and be blessed. Thank you very much.
Thank you, sir. Thank you for taking us to a development journey step by step. Classification of different type of cells with clear distinction and with percentage. Parasitic index, blast, vacuolations, nucleoli are all so clearly visible. We are amazed to see the features of digital morphometry. It was a wonderful presentation. It was interesting to hear about recent advances, particularly slide cases were very interesting, and the emojis were actually interesting. So we'll be taking questions later on after the panel discussion. Today we have very interesting observation. We have speakers and doctors from 4 metropolitan cities of India, like Srinivas sir is from Chennai, Dr. Bhagwat is from Kolkata, and Dikshit ma'am is from Mumbai, and I myself from Delhi. So we are talking about technology and see how technology is connecting 4 different cities across India. Now, moving to the second part. Now moving to the next session, views and reviews, we have panel discussion. So we have 2 experts from the field of hematology for panel discussion. We have Dr. Anupa Dikshit, she is MBBS MD from Gandhi Medical College, Bhopal. She is associated with Suburban Diagnostics, NABL and CAP accredited chain of laboratories for past 16 years. She is currently heading the lab operations as laboratory director, and her area of interest are technology upgradation and advancement at par with global requirements. She is active in conducting workshops, quality circle meet, CMEs, training, and is also an NABL assessor and MMC accredited speaker. And she is behind the Hello and CellaVision installation and validation at Central Processing Lab, Mumbai. Welcome, ma'am. And now we have Dr. Gautam Gopal Bhagwat. He is consultant hematologist, section head of hematology, immunocytometry sections at Suraksha Diagnostics, Kolkata. He has done fellowship in laboratory hematology from Tata Medical Center, Kolkata, and he has got hands-on training at University of Salamanca, Spain, in flow cytometry and in analysis of various hematological malignancy and MRD analysis. And in the year 2019, he received the Berenhoven Travel Award at the annual conference of ISLH in Vancouver, Canada. And his area of interest are hematology, oncology, and flow cytometry. So we have 2 experts from the field of hematology and who are well versed with digital morphometry. So now moving to the questions. So in today's time, our all actions are keeping in view of the current ongoing pandemic. It has changed the world. It has changed the way we think. So this non-touch technique is due to the current scenario, or this is long due in field of the hematology. Ma'am, your views, please.
Thank you, Ankur, for the introduction. And yeah, it's a very important question. Whether we need a non-touch technique, either ways, having COVID around or without COVID either. So I agree, and it's very, very important that we have a non-touch technique. And why are we talking about this? The reason being, we all know as a laboratorian that a slide which comes to us, or a sample, patient sample which comes to us, goes through immense number of steps before we give the final diagnosis. So there is a complex series of events where we have review mechanism, we review the slides before giving the diagnosis. And integral part is the sample goes to the automated analyzer. Then there is a review criteria. Now this review criteria depends majorly about how you have as a lab devised your own lab review criteria basis the ISLH guidelines, basis your middleware link, whatever you are using. And the slides which do not comply with the review have to go to manual review, which is the manual mechanism. Now, when we look at the manual mechanism of review of slide, incorporates a lot of tedious labor task, which is accompanied along with it. It takes time, it takes efforts, it's quite cumbersome. You need to be physically present to do it. You need to hold the slide in your hand. And there are a lot of challenges which are associated with it. And yes, during COVID, also, it has increased the problem for the labs to report a slide when you don't have shortage, you don't have enough staff available with you. And yes, it's very important because there are challenges which need to be taken care of when it comes to your touch technique. Although that's something which we still believe a lot in, being pathologists, still gold standard for us, where we manually want to review a slide. That personalized touch, I think, is immensely important. But now looking at the digital option, which is now replacing the personalized touch part with a very superb way, as Dr. Srinivasan has taken us through the entire journey, and with the cases that he has shown to us, it has added a lot of value. And yes, this is extremely important. I agree with this question of yours, where we definitely need to have a non-touch technique. There are problems of the physical review of the slide, which includes the slide storage part. There is a limited specialist opinion which can be taken when you have a slide being seen by you. You cannot take a peer group analysis or their review incorporated in the diagnosis. It's labor intensive. Then you, as a standalone lab, we have a lot of pressures regarding the turnaround time, regarding picking up the conditions which we are normally not able to do so. Faster TAT, then consistency and standardization. I think if you can bring standardization in the scenario, a non-touch technique definitely would be a big game changer for all of us. So agreed with this, Ankur, and this is my viewpoint. Our current scenario with COVID also in place definitely demands for a higher technological intervention, where we can actually bring standardization and take care of a lot of problems that we face with the manual reporting of slides. So agreed with you completely on this.
Thank you, ma'am. Very well explained. Dr. Bhagavat, what's your say on this?
Yeah, I would second this to Dr. Dikshit. And first of all, thanks a lot for inviting me. And Dr. Srinivas has really made our jobs very easier. He has elaborately explained everything, touched upon all the points. Coming to this, I would just add on to Madam's point that even the International Federation for Clinical Chemistry and Laboratory Hematology suggests, even they have given a guideline that all the blood hematology testing should be conducted on an automated instrument in a closed system. So even the guidelines suggest that now everything should go there, and we all know the slide making, a peripheral smear, manual making, you will have to open up the EDTA vial to take out the blood. Howsoever you try to prevent and do non-touch, but there you will have to touch it. So in that, doing a smear on an automated machine and then digitalized way of looking into it, definitely in this pandemic, everything is changing, and we must change our techniques also. And I totally second to this, that we must have a non-touch. Yeah, sure.
So means it was long due, but this COVID has fastened the procedure. Now we are in a hurry for going for digital morphometry. Yeah, right. Very well.
Yes.
Now coming to the second question, we all are accustomed to see slides on high resolution microscope or in oil field. We have been doing this since PG days, right? But now, like, how different this digital morphometry is? The process of being there in digital morphometry or in conventional microscope, how it is different? Is it accurate? It is cumbersome? Like, what you say? I would like to take first opinion of Dr. Srinivas. Sir, what's your opinion on this? Sir, your voice is not audible. Sir, there's some problem. Sir, I think you can reconnect. By the time Dixit ma'am, you can answer, please.
Ankur, so what I want to talk to you about first is how we got this entire system of Hello and along with that a CellaVision a couple of months back. So we being a standalone lab with chain of laboratories across the Western India part, we have both segment of patients which come to us, which is the wellness segment and also the sickness segment.
Right.
And as I mentioned earlier, we have a lot of constraint when it comes to the quality, the turnaround time, the consistency, the standardization across labs and all. So these were the challenges when we thought of getting this automated system. And when we got the system, we were following a particular step of workflow in the laboratory where a patient sample would be received in the lab. Then it will go to the automated analyzer, which is a flow cytometry based UBIZEN in our case, a part of Hello system, and the processing will happen on that. Now, as per ISLH guidelines and various review criteria, we have our own slide review criteria. Basis that the slides which fall under review criteria goes to SPS, which is the automated slide maker and stainer. Once that is done, as a part of validation, which is ongoing currently, we put the slide and we load the slides in our CellaVision, which is DM12, the one which we have. Now, it was very simple for us. Before doing this is, before getting the DM, we were reviewing the slide on SPS manually and we were reporting. And the slides which were not falling in the review criteria, we were still screening them and we were releasing the report. That was the simpler way we were handling the lab workflow when it comes to hematology. Right. Now, since we have started validating DM12, and trust me, it's a very extensive validation. We defined the timeline for it. And what we realized is we have run around 500 samples, but that's also not enough. As Dr. Srinivasan mentioned, you need to run 50 samples. I think 50 is such a small number when we look at this big technology. And it's actually taken a big task for us now to validate the entire CellaVision as a system, where we have incorporated few change. And this is what we are looking at also going ahead is, we will have the samples still getting processed in the same automated analyzer. We have our review criteria set. It'll go to SPS as the automated slide maker. And yes, we will manually upload it in the DM12 system. Now, there is an advantage to us with us. We have a very smart middleware, which is P8000. Now, this becomes the heart and soul of the entire system, which passes on the information between the instrument, the SPS, and the CellaVision. And that's the beauty of it, because at the central platform like P8000, you are able to take clinical decisions very, very easily. You know what slides to actually pay attention to and the slides which we really don't have to look into details, because now it's a very beautiful analysis which we are still not able to complete, but we have few insights into it as to how the performance of three systems work together. We have information going back to P8000 from all the three components which I just spoke about. And clinical decision, currently we are taking it manually, but we have every slide go to DM12 now, which is passing or getting incorporated in our slide review criteria. So there is a deviation and the workflow is fast. Although we need a dedicated person now, a technologist or a pathologist who gets into reviewing the slide on the screen, where, as sir also mentioned, Dr. Srinivas, there is a beautiful depiction of all the cells together in one screen and one dashboard. So sorting is very easy. Your confidence is much higher. There is a standardization. You know what you are doing. Actually, you know what it's. There are limitations to it. I'm not denying that there are not limitations to DM12. There are plenty. But once you know what you have in hand and you work towards the solution, I think it's a very good, complete system. So yes, there is a workflow change which we are looking at completely. And feel factor of digital system, I think it's a way ahead thing. I mean, it's a long way ahead, and we have a lot of work to do still, but it's going to definitely change the entire way we report a slide. I'm very confident about this.
Very likely. There is a change, but it's a beautiful change.
It is indeed.
Yeah. And what you say, Dr. Bhagwat, on this?
Yeah, I don't think the process in terms of the term process has changed from digitalizing, because there has to be a trained and skilled hematologist, whether it be a digital platform or whether I am seeing it through a microscope, because there is a reclassification thing that has to be done. So the process essentially remains the same. A good sample, all pre-analytical boxes ticked correctly, all you get a very good slide, good quality slide, and then you view it under your microscope or you view it on a digital. The process it is same, but definitely the feel is quite different with the digital thing, and it is much better. And this change has to come in the what we are facing in this era of work from home. I'm sure that I'm not saying that I'll not go to the lab, but I would be very comfortable seeing slides at my home. If there are any urgent samples, it would take me time to go to the lab. Second, any odd hour samples, APML coming in night, which we have all faced, I would be confident enough looking into a digital image at my home, though I would go to lab to sign out the report maybe at present, because the Ross curve of change, as you know. So first I am in a shock denial to take up this change, but then at the ultimate curve ending with time passing by, my performance increases if I accept this change and I integrate into my system. So with all these things coming up, the feel of digital system is much better than what of the microscope, but this change has to be accepted, and this is the talk of the day, the digital way going ahead. I think our radiologist partners have all gone digital, and now it's time that we as hematologists also this trend of reporting on this digital system. So coming to this question, I won't say the process has changed, but the feel and definitely the quality, maybe I'm not sure, but quality has definitely would improve with this digitalization.
Very rightly said. First there is denial, but once you accept it, then it becomes absolute compulsion, and sorting makes life very easy, right?
Yes.
Srinivas sir, what's your say?
Yeah, I think the other two doctors are really put in their thoughts, and that's right. So I have few things to say, because the digitalization does not say that the manual will go off. The manual review still continues. Okay. So the manual review, when does it continue? Whenever you have got some limitations of the digital imaging, what we were talking about. So let me just give you a simple example. If you have severe anemia, say you have got anemia of about 3 grams of hemoglobin, and if you do a smear, do an automated staining, and put it into the digital CellaVision or whatever you call, it will not get scanned. You have to do a manual review. That's basically because the stain intensity is not picked up by that, and you will not be able to get anything. That is one of the limitations which I have seen. The second important thing is that whenever you have got, I'm talking now about the advantage. Whenever you have got a leukopenia and your patients are also having pancytopenic, and you want to pick up, you have got a blast cells. I vouch for the digital imaging rather than my microscope itself, because it is able to give us unclassifieds. It is also able to give a blast, go for the image bank, check it up, and then you can sign out with that of the leukopenic samples where you are having a low blast count itself. I think, Dr. Ankur, it is the laboratory's perspective to understand after the verification that which will go in for a digitalization, which will go in for a digitalization plus manual review. Both will be there, but I can agree with you that digitalization will bring you a faster turnaround time, faster pickup at any point of time, 24 hours, 365 days. You can do WhatsApp with the images and you can send it, or you can have a remote sensing and you can send it. This is my way of thinking about it. And definitely we have to adopt the new norms. There's no go about it.
Right, sir. One thing I find, it will be very difficult for small lab chains. for small laboratories to go for digital, seeing the cost factor and many other things.
Agreed.
Now coming to the next question, many a times there is low abnormal cell count on slide. Sometimes it becomes very difficult to diagnose malignant cases on slide because of the low malignant count. So this digital morphology is having boon on the conventional microscopy. So Dr. Bhagwat, what you will say on this?
Well, I think Dr. Srinivas is a better person with such a huge experience with this digital platform. But yes, I whatever I have seen with this, low abnormal cell counts, although microscopy, it is difficult, it is labor intensive, it takes, and when it is really in the evening at 7 o'clock when I'm looking at tired eyes, I might miss something, which is not going to happen with digital thing. But I think with that experience, Dr. Srinivas would be a better person to take this question.
Okay, Srinivas sir, please.
See, I told you previously itself, I gave you an example. When you have a pancytopenia with leukopenia, the digital morphometry does a better job to pick up abnormal cells, put it into the pre-classification of the blast cells. You have to resort it, seeing across to that of what you have got. I'll just give you a simple example, not on that of a leukopenic sample. This was a sample with the liver failure in a COVID patient. When we were putting it, the smears under the CellaVision, we were able to pick up what is called as a suspected blue-green crystals of death, which is one of the most critical and very abnormal WBC inclusions which we have to tell to the clinician. Okay, so we had to correlate with other parameters and tell to the clinician that, look here, doctor, we are seeing some suspected cases of crystals of blue-green crystals as an inclusions in the WBC. I took the same slide and put it under a microscope and start searching. You won't believe what my experience was. I spent nearly about 25 minutes to search. I was not even able to get one cell. But took the same slide, put it back again to the CellaVision, it automatically brings back to the same cells what you have seen. So that means the taste of the digital morphometry should be experienced once, and then only you will come across to that of the digitalization of your things. Of course, low abnormal cell count are difficult to get on microscopy, but definitely helps on our standardized digital morphometric experience.
Absolutely, sir. Absolutely. Now we'll be moving to next question. What's your say on the pediatric samples? Like many a times lymphoblast creates a problem on the slides. So what you will say on this digital morphometry? Ma'am, please.
Yeah, Ankur. Ankur, before that, I would like to just share the experience that we have during the validation. Is it okay if I share that?
Yeah, sure.
To answer your last question as well on the low cell count. So basically, when we did the validation, we were able to demonstrate that the instrument yielded reproducible pre-classification results for neutrophil, lymphocyte, monocyte, eosinophil beautifully, including the blast. As Dr. Srinivasan mentioned, it's very sensitive for blast pickup. Although there was a challenge with the low cell count, which was basophil, and the band forms we found were not very consistent with what we were getting in the manual microscopy. Beautiful part is, in cases of penias, the neutrophil count came exactly the same as we were getting with our instrument and with manual microscopy. So there was a good correlation with the microscopy part. But entirely overall, if you ask, the pre-classification accuracy fell more than 90% in every kind of scenario that we tried to do the analysis with. In fact, we had some challenge with monocytes, where monocytes were not coming the same as we wanted it to be, especially in cases where atypical lymphocyte counts were high. We took an entire bucket of atypical lymphocyte count and we realized the sensitivity was only 50% when it comes to picking up of atypical lymphocytes, which were any which ways getting counted in monocytes. ILC also, the sensitivity was falling around 50 to 60%. So these were the few buckets which we tried to pick up and work on it. But yes, the sensitivity for the low count is quite variable because of the less number of cells which are seen. As we all know, CellaVision or the digital morphometry will pick up 100 cells only. It will count 100 cells, not beyond that. Although there is an extended mode, where you can have 1 minute extra and you can pick up more cells, around 300 or so, and get an accurate diagnosis. But I think that sometimes we feel it's better to do a manual microscopy in that case rather than running 1 minute extra on the slide. So a lot of experimentation still going on, but yes, that's the field factor we have. And yes, we also ran few pediatric samples, but there was a challenge. When we ran newborn samples, we found that the consistency and accuracy was not seen.
Okay.
So pediatric samples, newborn especially, we were not able to get the sensitivity, and also sometimes we felt the lymphoblasts were not picked up properly. So there was a decreased sensitivity and specificity on the same. Probably Dr. Srinivasan can share his feedback also on that. And I really don't know the reason why it happened. Maybe because of high PCV, that the cells were broken down while preparing smear, we were not able to get consistent results. Dr. Srinivasan, your views on this, pediatric samples?
Okay, see, we don't have an active pediatric wing. That is one of the drawbacks. But however, whatever the pediatric cases we had seen, especially the newborns, we have found out that the digital morphometry is of not use in this. So if you give me just a fraction of the second, I'll just read what I have in my hand with this ICLH guidelines with respect to the pediatric samples and the digital morphometry. Give me just a fraction second.
Sure.
Yeah, sure, sir. So this is one of the limitation, I think.
Right.
Pediatric samples.
Not pediatric per se, but newborn, yes.
Newborn.
Rest of the samples are still all right.
Okay, I just got this. So I'm just reading it from this paper. So this paper is actually digital morphometry analysis in hematology, the ICLH review and recommendations. And I'm reading from the guidelines itself, which is written by Karzat et al., which says that for the pediatric samples, as Dr. Anupama was talking about, the detection of the lymphoblast shows a low sensitivity. Okay, and specificity in the pediatric samples and shows the lowest rate of overall accuracy itself. So what Dr. Anupama is saying, I did read also, and I just wanted to tell you people this is what it is. And it also says that the CellaVision has got a time-saving scanning WBC for the diagnosis of the lymphoblast, and it can also pick up something to do with that of the storage diseases if you have a bone marrow. Okay, it says that the sensitivity of the pediatric population had excellent positive predictive value and sensitivity for the blast cell identification in bone marrow rather than that of the peripheral cells.
Okay.
So I'm just reading it from this paper itself so that people can go back, freely download this paper, and they can apply it in their practices itself.
Right.
Yeah.
Like,
Thank you for
I
sharing.
like to add on this regarding the pediatric sample. So one thing which I noticed when we had our pediatric samples, the automated slide maker stainers usually give you that monolayer to see. So it is the same challenge as it is under a microscope. It is the similar challenge you will face in the digital. If the slide is properly spread and you get a good slide, there is no problem in the digital thing. Moreover, any automation, be it flags in your hematology analyzer or be it this digital imaging, lymphoblast, especially those L1 types, those require trained and skilled hematologists, and only and anyways, a digital platform till now we are not going to just go through, send the reports to the LIS directly before. So you have to go through all these cells, and then you can very well reclassify. So I won't say this is a limitation. This might take some more time, but this is not a limitation. Pediatric samples go very good. Just that we cannot rely on the pre-classification, as ma'am said, that the consistency and reproducibility is hardly 50%. But if I in a manual intervention in that terms, but on a digital image, we can very well classify a lymphoblast and reclassify the lymphoblast, which is mistakenly put into a lymphocyte. So I won't say this is a limitation as such. But yeah, digital morphology may provide additional advantage because then I get to see so many cells into it, and then I can classify it properly, which I might miss on the
right. Means there's a lot to explore.
Yeah, it's lots of things to forward. Yeah.
Every day there is a new learning, Ankur, on this.
Yes, very true. Now, Coming to the next question, can digital morphometry be used for body fluid analysis?
Yeah, Ankur, you can use it. We have options of using it in body fluids. You can also use a urine cytospin, CSF cytospin, any of the cytospins you can put into the cell vision.
And so this is as sensitive as blood samples?
Yeah, it gives you, but I always feel the body fluids has to be used as a glass slide. That's my vote on that. That's it.
Very true. And I remember my PG days. In our college time, we used to be very excited about pentan. And now I wish we had this digital morphometry thing at that point of time. So what's your say on digital morphology? Is digital morphology helpful in training and teaching?
I think I should first ask this to Dr. Anupama because she's using this for her group of chains of laboratories. So I feel it was useful. So Anupama?
So it's too premature for me to actually vouch for it right now. But looking at the options available when it comes to teaching, training, competency, I think it's extremely important. And we currently have one system which is in our centralized lab, not in the peripheral, so there are limitations to it. But yes, we have an entire set of library which can be created. That's what the insight is. A beautiful library can be created. And we can actually have a lot of other options available with that, like Vision software, where we can actually go and see and have our questions ready for our staff. So that is one thing which we are planning to do very shortly. Second thing is about television has an atlas, which sir, you also mentioned about the availability of that atlas, which can be on your phone. You can look at the morphometry, the description of the cells, and if you are lost whether which cell is what, you can always refer back. There is a quiz attached to it. So there are multiple tools which I found are already available. And this is the most tempting part, I think, going ahead when you have a huge set of stuff with you, technologists with you, you would really like to take this initiative. So yes, so this is the dream for us now to put this to action and take it ahead.
Ma'am, I think your students will be very excited about this thing.
Of course, of course. And as sir has shown those beautiful unicorns, 1, 2, 3, I think that's quite fascinating.
Sir has shown so
like that now.
No, Anupama, it was as exciting as you people are when I saw it because my technicians just got this and they said that this is good. Yeah.
So beautiful to look at.
So you shown such beautiful slides. I was amazed to see like RBCs sorting out this parasitic index and everything was so beautiful.
That's right. That's right.
So this, I think we have already discussed about the advantages and limitations of digital morphometry. And the next question is also same again, like advantages and limitations of the conventional microscope. It does go hand in hand. So we can just summarize and club these two questions.
Sure. We have already finished all this.
Yeah.
I would like to add something in the disadvantages seen with digital morphometry.
Please, ma'am, go ahead.
So basically, as we discussed, neonate samples definitely needs review. Neonate or pediatric with leukemia needs review, which you cannot work on digital. As of now, this is what our experience says. And when there is a suspected dysplastic cell in the form of lymphocytes, that again becomes a challenge. Malaria, it gives some indication about malaria, but unless you do a manual microscopy, there is a tendency to miss out on malaria. So that's a babesia. Like we get a lot of animal samples also. That's a challenge. RBC agglutination, we need manual review. Platelet clumps, although the sensitivity is pretty good, but still you end up doing a manual review. That doesn't go off you. Then the platelet population, I think, still needs some work on, where we still have to review. Our criteria has not improved too much when it comes to platelet population in the review. And also whenever there is penia sample, though WBC and abnormal cells are suspected, although you will rely on digital, but a manual microscopy is definitely not ruled out in such scenarios.
Right.
So these are a few insights on the validation that we've been doing, and this was our outcome.
So, Dr. Ankur.
Yes, sir.
Yes, sir.
Dr. Ankur, this is your co-moderator speaking, Dr. Prakash.
Yeah,
I
Dr.
think
Prakash.
the session is entirely beautifully taken, and as we see the acceptance of automation happened in the last few years of laboratory medicine, this would also be one of the part and parcel in coming time. And I could see many questions coming up on the screen, which more also have been answered. So after listening to the presentation, the discussions, I have just one general questions to all of the panelists. I mean, that can be answered right from Dr. Srinivas to Dr. Anupa and Dr. Bhagwat. What is an actual challenge as a morphologist or for a morphology? Is it the analytical? Is it the technical? Or is it the subjective?
You are talking about any... Hello, Ankur?
Yeah.
Yeah. Can you just repeat the question once again?
Dr. Prakash.
Yeah, this is the question, and I think it is a very general question, sir. But as a pathologist, morphologist, this questions keeps on coming every time, and that is why the things keep on happening, reviews and the views. So my question is very simple to all of the pathology fraternity, and because we are representing the pathology forum right now on this dais. So what is an actual challenge for a morphology today, or it's been there since a long, or a challenge for the morphologist to give a morphological diagnosis? Is it an analytical or a technical or a subjective?
Subjective.
Correct. I agree with you, Anupama.
There is no standardization anywhere, neither in pre-analytic nor in analysis, which is
So
the microscope.
then to add to this question, do automation like digital morphometry automation, or in slide preparatory systems, or making a little bit of intelligence of the new part hematology analyzers, would cut down to the subjectivity, bringing an objectivity and standardizing the process and the procedures in hematology practice or in lab medicine would be helpful?
I think it is need for that every stage, whatever you have told, from the CBC automated analyzer to that of the smear maker, stainer, to that of the digital. Every of this should be in synchrony to make sure that the verification and the verification has happened at each of this level to put it into the use. In that way, we will be eliminating the subjectivity per se itself. And you bring in some system process for your full automation of the hematology unit itself. That's what I feel. There is a need for verification of individual things, including that of your automated hematology analyzer. Then you get on to the smear maker, stainer, and that of the digital morphometry itself. Even in the digital morphometry, as we were talking about the limitations, that can be conquered only by the time phase and the feedback what we are going to give it to that of the manufacturer, so that they'll be able to get us a better software to classify these cells. That's what I feel.
I agree with you on this.
I think the way forward is to club cytomorphometry given by the analyzers into club it with the digital morphometry and looking into the flags over there and the cells over here and combining it in a very short time and reporting out as soon as possible, giving critical alerts. That is the biggest advantage that I feel we will have with digital things coming up, and that we are actually practicing now.
Correct. You're right.
Thank you, sir. Sir, there is one question for Dr. Dharav. Is there any time limit for sample processing after sample collection in digital morphometry?
No, there is nothing. If you are following the pre-analytical properly, I don't think there's any time limit for that. It is open 24 hours, 365 days. You can open your digital morphometry and you can go ahead.
Right, sir. And so one more question is there, since it is based on smear assessment, does environment variables like humidity has any effect on performance?
Oh, that's what I showed. The quality checks are done on the slides, and then only you're going to put the slides on it. And any of the slides which are having a bad staining, you will not be able to report on it. You will be getting a rejection, or you can see the air bubbles, acanthocytes, what you call as abnormal water droplets, and the scanning will be blur. You may not be able to see the images.
And this is the way, Ankur, where we bring standardization and quality check in the pre-analytic also. Otherwise, we never were careful about what quality of slides we were getting. We were just rushing up by doing a microscopy. Now we actually know that the quality needs to be good. And in a way, it's helping end to end, pre-analytic to analytic.
Exactly, ma'am.
With the quality check going around, and what I am going to see under a microscope, if I can report it on a microscope, I can report it on a digital morphometry. Yeah.
That's right.
So, Dr. Prakash here again. So, what should be the, to conclude in a way, is seeing is still believing, or is seeing has to be believed and accepted?
It's a very tough question what you're asking. I only go on a cycle now to balance both. That's it.
No, sir, everybody is we come from a morphological background, so we all know there would be a subjective errors and differentiation in variables. So I had been asked in this way, seeing is always believing. So things are coming into picture. Maybe seeing may have an objectivity here somewhere to get a standardization. This is the only idea about this entire webinar today, or sharing the experience and the knowledge, so that even with the bits and parts of the automations available today, can be a good process in standardizing everything what we see, and we can give a good objectivity towards our reportings or analytics.
That's right.
Seeing along with technology intervention, the right technology intervention, where you have analyzers which give a added feature of flags or characterization, I think that will close the loop completely.
Maybe that's the way to go ahead, and I think we have very well utilized the entire timing of the presentation, the questions, the discussions, and the questions what we got from the entire fraternity joined today herein. And I think it was a very beautiful session, and a very, to break the monotony of the COVID, we need to even go back to our basics, but with a tinge, as we have become more virtual in our day-to-day activities, so acceptance level to these kind of activities would be much more higher now. Over to you, Dr. Ankur, so that we can go. And thank you so much from my side, and from everyone who has joined. Thank you so much. Over to you, Ankur.
Exactly, it was a beautiful session. I was myself amazed by seeing slides and many new things I discovered in today's sir's presentation. It was a beautiful presentation, and we had a nice and very enlightening discussion. So thank you so much, Srinivasan sir, Dr. Dikshit, Dr. Bhagwat, for such a wonderful and knowledge sharing session. And so to sum up, to conclude, digital morphometry has definitely got an S over conventional microscopy, and this is the need of the time. So when the hematology analyzer, when clubbed with digital morphometry, it can give wonderful results. And by this, I conclude this session. And thank you so much, our presenters, speakers, Dr. Dikshit, Dr. Bhagwat, and Srinivasan sir. We are very enlightened and we are grateful. And thank you to the audience for giving their time. Stay safe, wear mask, use sanitizer, and thank you all. Goodbye.
Thank you, Ankur, and thank you, Team HORIBA, for this.
Thanks.
Pleasure, ma'am. Pleasure, sir. Thank you.